Good morning and a warm welcome to KBC News Check on this 24th day of January 2024. My name is Njue. Lensa Odingo will be our sign language interpreter for this live program. This is a program that we ensure that we keep you afloat with all the latest happening, current affairs, sports, business, all that in one. And today we'll be discussing matters health. But since this is a program that ensures that you are in the know with all what is happening in the country, of course, Africa Cup of Nations. Also, we are keeping tabs with what is happening in Ivory Coast. Yesterday, about 4 matches were played, and today we also have other matches in the last group stages. But that's sports. Away from the sports, we are discussing matters health today, and the Court of Appeal gave a clean bill of health to the Social Health Insurance Fund, which now give way for the implementation of the affordable health care, which is one of the pillars of President William Ruto since his ascension to power. And before I introduce my panel of experts who happen to be doctors in various fields, let's have a look at what has led us from NHIF to SHIF. The SHIF Act was signed into law by President William Ruto in October of 2023, and the act also enacted by the CS Susan Nakumicha and also gazetted on November 2023. The High Court halted its implementation in November of 2023, and the Court of Appeal lifted the ban on the implementation last week. Remember, the regulations do not necessarily require the approval of Parliament before they become operational. Remember, the Ministry of Health also established regulation that will enable the implementation of the Social Health Insurance Act 2023 in place this week. The ministry is working round the clock to ensure that the issues raised by a number of issues, including the Kenya Medical Practitioners and Dentists Union, and also raised by the High Court, are cleared, and we will be having the Social Health Insurance Act ready to go. And the regulation seeks to enhance contribution to the Social Health Insurance Fund, making salaried employees contribute 2.75 of their basic pay and about 300 per month mandatory minimum contribution from unsalaried people. That led to the rise and passing by Parliament of 4 laws, key laws that will actualize or make the basis or the framework to actualize the affordable health care in the country, which happen to be the Social Health Act, Insurance Act. We also have the Primary Health Care Act. We also have the Facilities Improvement Financing Act, and last but not least, Digital Health Bill Act. And this also of the Social Health Authority, and it's a good thing that we have the chairman right here in studio to give us a feel of what exactly Kenyans should expect as we actualize the affordable health care. Remember, the plan of the president or the government is to transit to the universal health care where no one is left behind. That's the topic that we will be discussing in this first hour. The second hour, we'll be discussing matters South Sudan. Yesterday, the head of state did say that Kenya is still committed to actually helping out South Sudan, who are having their election this year. Remember, they are our neighbors. Millions have fled their country, and some of the South Sudanese actually reside right here in the country. We will be looking at that in the second hour. But without further ado, allow me to introduce my panel of doctors. Beginning from my immediate left, we have Dr. Timothy Olweni. Dr. Olweni is the chairperson of the Social Health Authority, which has been established via this Social Health Insurance Act. And just next to him, we have Dr. Oyimbo Kerema. Dr. Kerema is the Kenyatta University Teaching, Research and Referral Hospital Deputy Director, Clinical Services. Madaktari, karibuni.
Thank you.
Perhaps to begin with you, Dr. Timothy, tell us something about the mandate of the Social Health Authority, which is a new body which will actualize and assist the Social Health Insurance Act.
Thank you. The Social Health Authority is a body which has been set up as a vehicle to be able to help Kenya in terms of achieving universal health coverage. It is important to clarify that the Social Health Authority has got a wider mandate than the current NHIF, than the NHIF that was the predecessor. And it has got 3 funds amongst the Social Health Authority. You've got a primary care fund, you have got a social health insurance fund, and you also have an emergency chronic and critical illness fund. So the mandate is wider, and the spectrum of activities that it's supposed to engage in terms of financing is also wider.
Good, and it's a good thing that you'll be telling us about those three funds and how they are going to be helping Kenyans, especially those with chronic illnesses and also those who cannot be able to pay the 300 shillings, because the president said no one is being left behind. And to you, Dr. Oyimbo, we are looking at an issue that has been raised by the Kenyan Medical Practitioners and Dentist Union. I'm quite sure you are a member of that union. They said that a lot of stakeholders, including doctors, were not involved in the establishment of the Social Health Insurance Act. And the train has already left the station, but Kenya Medical Practitioners and Dentist Union has also raised concerns in regards to how they are not quite being involved in the process. I would like to pick your mind on that. The public participation is currently ongoing.
All right. So the entire conversation about formation of SHA and all the three, the conversation started way back in 2020. There's a whole group that was working on it, even before the current government came into power. So the conversation has been big and continuous, and lots of people have done good work for us to develop what is currently ongoing. What we had was good, but it was possible to improve it. So I think it is important to note that a lot of work has gone into this entire topic. The fact that we have thought about a primary healthcare fund and moving the conversation from curative to preventive, and that is the reason that we have the primary healthcare fund, that makes it very important. It is a very thoughtful, and there's a times 900 times investment. You are able to, by concentrating on early diagnosis and prevention, you are able to save 900 times on what you'll be spending on curative. So the truth of the matter is there's a lot of stakeholders and partners who have spent time to consider these three laws and the way that we can actually make universal health care achieved. I have to say this. The previous generation that of the doctors who tried to shepherd healthcare from independence to say 1980, they tried all they could, but they did not have a lot of political support. And then there's this team from 1980 to say 2000. They tried all they could, but they couldn't. There was not much money, there was not much political involvement. But then there's what we are having. We're having, in my opinion, an opportunity to deliver universal healthcare in our generation. And if we fail, if we miss this window, it's called a window when policymakers find political goodwill. We cannot miss this window. I think it is important. We might not agree 100%. There might be a few things that we disagree. Of course, nobody agrees with you. But the important thing is we should make movement. I think this is my opinion.
Yeah, indeed. And Dr. Olweni, we are looking at the NHIF, which was there for 57 years.
Correct.
Now we have SHIF, and the SHIF has also given birth to triplets. As you've said, primary healthcare fund, we have the social health insurance fund, we also have the emergency and chronic and critical illness fund. Let's first of all start with the primary healthcare fund before we even go to the semantics themselves, because a lot of Kenyans have raised concerns, and despite, leave alone the 2.75%, I would like to, even if it's 3%, if at all that money will be prudently managed, I wouldn't have any issues with that. And I'm quite sure a lot of Kenyans can resonate with that, bearing in mind that a number of Kenyans are just one illness away from poverty. How is SHIF going to actualize the three funds? Let's start with the primary healthcare fund.
Yes, just to give it a little bit of background. First of all, we must understand that subsequent to the passage of our 2010 constitution, healthcare is a constitutional right. Access to healthcare is a constitutional right for Kenyans. And therefore, it is also an imperative for the current administration and any government that you provide that care. Now, the care that, as my colleague has mentioned, in the past, people concentrated too much on providing curative services. With this new system that we are trying to put in place, we are trying to provide end-to-end care in terms of starting from preventive care, promotive care, curative care, rehabilitative care, palliative care, all the way up to referral services. So we're providing the entire spectrum. That is where now the issue of the primary care fund came in, because NHIF in itself, the mandate was focused on curative care. Now, there are also the aspect about for us to achieve universal health coverage, we have to bring down the cost of healthcare. And this is one of the strategies. The saying, a stitch in time saves 9 works. And you can see the number 9 also comes up with the figures that he was talking about. We have got to be able to save costs downstream by intervening early. So in terms of screening, in terms of being able to catch illnesses early. And he gave the example, for example, if you give an example of cancer. If you catch somebody in stage 3 and 4, first of all, the outlook is much more bleak, but secondly, the costs are much higher. So we want to be able to, first of all, put in this primary care fund, which did not exist before. And that's why I keep talking about the wider mandate. And I want people to compare apples and apples, not apples and oranges. So people compare the NHIF and keep saying, why did we dismantle NHIF and yet it was doing the same thing this new scheme is doing? They're not the same. Then secondly, you must remember, so that's the primary care fund. This is going to be provided all the way from level 1, where community health promoters go to households, and then to level 2 and 3 facilities. Then after that, you move on to level 4, 5, 6 facilities where curative care is provided. And that is where that is now the realm of the social health insurance fund. That is where we're going to be financing healthcare in those segments. Then another problem which we had before is the issue of emergency care. And that again was something that was legislated upon, and it is a right. Section 43(2), it is a right. Nobody shall be denied emergency services. The question was, how do you operationalize that? In 2017, they talked about, there was a health act in 2017, but there was a fund which was supposed to be operationalized. It was never done. Because at the end of the day, you've got a difficulty where people need emergency care. But healthcare providers are going to be reluctant to provide that care, and especially in the private sector, because who is supposed to foot the cost? If it is a right, that addressee of those rights has to be the government. So again, we've got the emergency chronic illness and critical fund, which is taking care of that. You must remember these two funds, the primary care fund and the emergency chronic and critical illness fund, are funded by the exchequer. Everybody is entitled to that, regardless of whether you have registered and paid for the social health insurance fund. And that is important. Very important. It is funded by the exchequer, so nobody is going to be denied those rights. The one that is a member's fund is the social health insurance fund, which comes in the middle. So once you access your service in the social health insurance fund, for example, you exhaust them because you have a chronic illness and so on, then you move on to the emergency chronic illness and critical illness fund. However, the emergency chronic illness and critical illness fund, emergency care is for everybody, but for you to get the chronic illness fund and so on, you must be a member of the social health insurance fund. So I think that clarification is important. So you can see the entire spectrum of illnesses is covered in this new scheme as opposed to what NHIF was covering before.
And we'll crunch the numbers because the figures are staggering. 133 billion that the government intends to actually boost, because the increase in the deductions by 2.75% is going to at least put a big kitty, and especially for the SHIF, now that we've transited from NHIF. The Facilities Improvement Financing Act, this is a framework that will also provide funding and financing for institutions, including one like KU Referral. And this is supposed to help a number of Kenyans, many, millions, across the country. I'd like you to touch on that.
All right, so I think it's important to contextualize. So the Facility Improvement Fund, the FIF fund, it was meant to cure a disease that was primarily affecting counties, where hospitals would collect money and the money had to go all the way to the county and then repurposed back to the hospital. So eventually, the hospitals were now, whatever they collected, they could not plow it back into the hospitals for the use. So for example, I'm able to collect, say, 100 million. Okay, now that 100 million would help me buy gloves and non-pharmaceuticals and all pharmaceuticals and do all what is called operations. However, so you collect 100 million but give it all that to the county, then the money is repurposed to you, probably this time 50 million. So eventually the hospitals were unsustainable and they were struggling to work. And so the short answer to the need for FIF was to support the plowback of monies collected in our county hospitals and the sub-county hospitals to be reused in the hospital. So that is the disease and the cure of the FIF.
And still on that, the improving of the facilities, because at the end of the day, there will be a lot of money involved, and we're expecting that this money will cascade down to the healthcare facilities that offer the first line of defense in terms of healthcare provision, those in the rural areas. What are some of your plans? Because your authority also encompasses the SHIF, more or less like the NHIF, the new NHIF, to make it simpler for our viewer.
Just for clarity, you know, the Social Health Authority is not in the business of providing healthcare.
Yeah.
It is in the business of financing healthcare. So we benefit from the FIF in terms of our members are going to access better quality services because the facilities are running better. But when it's not within our mandate to run facilities or to be able to see how they run. All we do is facilitate them by making sure they provide services, and those services are paid for and paid for in time. Yes.
Yeah. And this is a big boost to some of the health facilities. Is there something you wanted to add?
Yes. Yeah. I can see. So regarding the rural hospitals, what we can say level 2, level 3.
Yes.
As Boss has said, they are supported by taxes. And so the PHC is actually, the primary healthcare is tax funded, and it supports level 2 and level 3 hospitals. That means outpatient care. You walk in with malaria and you get treatment. If you have diarrhea, and you can walk into a level 3 hospital, get your care and go home. So this, in my opinion, is a very big conversation, that all level 2, level 3 hospitals, you are able to walk in and walk out for both in and outpatient. Now, how much money is going to be PHC? Probably we'll be able to get that from the chair, but that's a lot of money to support all this level 2, and that is the universality about this. You are able to get primary health care at Mashinani. Now, the level 4, 5, 6, on the other hand, will benefit primarily from the SHIF. Now, SHIF, you can say, probably can be considered as the mirror of NHIF. So, SHA, and I keep hearing you say SHIF Act. It's called the Social Health Act. So the authority is the mother of these 3 children.
Yeah.
So the authority has given birth to ECCF, that's what we call it, the Emergency Critical Care and Chronic Disease. So the emergency part has the ambulance package, and he also has the emergency medicine package. So for hospitals like KUTRRH, we are leveraging to make sure we are ready to support the Social Health Authority with emergency services. So anybody with an accident, anybody with a heart attack, we have already set up a huge accidents and emergency, which has 16 beds. We are able to take care of all traumas to the head, to the abdomen, you know, so all those traumas we can take care of. We can take care from door to CT scan, takes us less than 10 minutes. So if you come with a motorbike accident and you get a head trauma, from door to CT scan, it's 10 minutes. I tell you, there are fewer hospitals in Kenya who can achieve that. All this is because we are preparing to support the ECCF, the Emergency Critical Care and Chronic Disease Fund. So how much money do we expect to be given to, say, ambulance services? We expect in the first year, up to the fourth year, there will be probably graduation of that money. But do we have ambulances? Our role will be probably to receive the patients. But as a strategic direction that this country should take is there will be money given by the Social Health Act. So the people who are ambulance providers will be able to leverage on that. And for those of us who are providing emergency medicine, we'll be able to provide access to emergency medicine, whether it is a heart attack, whether it's a stroke event, whether it is a snake bite. And then to the last about the ECCF, we're able to provide critical care. Kenyatta University Referral has 67 ICU beds. And this time it's going to be reimbursed at market rate. So whereas in the past we used to have about 19,000 reimbursement, and our expenditure per day in any ICU is between 30 to 40,000. So eventually now SHA is going to reimburse critical care and at rates that are marketed. So hospitals will be able to be, and this is the genius about this entire conversation. So SHA gives you PHC, which has a huge conversation, and there's a lot of the PHC that talks about prevention. And I think this is where you really need to concentrate. Primary healthcare will have a lot of prevention conversations.
Yes.
And so from screening of the prostate, of diabetes and hypertension, you know, so screening of CA cervix, cancer of the cervix. So all of this will be happening at the primary healthcare fund. I think it is important for Mwananchi to be able to understand these differentiations about SHIF,
yes,
ECCF and PHC and their role.
And let me pick from where Doc has left on the ECCF. That this is offered for even people with cancer, people with hypertension and all these nagging diseases. Mwananchi would like to know, where exactly will it start? Will it also cover, he will be covered in terms of diagnosis, in terms of therapy, in terms of medication? How far will it go?
There are no exclusions.
Including diagnosis?
It covers everything. That's why I said we're providing end-to-end care. So we're assuming, for example, you don't even know you have a hypertension or diabetes and so on. It's picked at the primary care level. Then you segue into getting care. You get care at the under the Social Health Insurance Fund. If, for example, for whatever reason, because of the kind of care you need, you exhaust your benefits under that, then you move on to the Chronic Illness Fund. So that's why I'm saying it's end-to-end care. And I want people to understand, what we're proposing here is radically transformative. The per capita financial inflows into the health sector are going to go up 3 or 4 times. That is how big it is. In other words, the funding that is going into the health sector is going to increase significantly with this. There are a lot of things that we had discussed in the past. And for those of us who've been in this health space for a long time, I've been in the health space for 30 years, I have not seen proposals that are this radical. And the good thing is, the solutions are crafted to cure what we have been complaining about all along. And that's why I want people to understand that there's going to be some pain. And I know there's always some financial pain, but it is going to be worth it in as far as all of us have got issues with healthcare. Every other day you've got a WhatsApp group where we're raising funds for providing medical care for somebody. You've got a relative who calls you from the rural area and says, I need to go and get this treatment, I can't get it, please send us money. Those are the kind of things we want to get rid of. But out-of-pocket expenditure becomes more and more a thing of the past. Let it be that you're spending money out of pocket because you want an enhanced benefit. You want to go into a room that has got better amenities. Those are extras, but in terms of the medical care itself, let the medical care be provided, and more importantly, let it be pre-financed so that you're not looking for money at the point of seeking care. Look for the money to pay the premiums. If you're unfortunate and you develop any illness or have an accident or need any medical attention, let it be at that point you're not seeking money to be able to get the treatment you require.
And Chair, because this is a question that somebody has sent, how do we instill confidence that SHIF will be more transparent for Kenyans who are skeptical, having seen how NHIF was?
Okay, I know there's a lot of NHIF bashing that is going on at the moment, and understandably so, because NHIF is not perfect, right? NHIF has made a lot of difference, and for me especially, I've been in the health space, I have said in the last 10, 15 years, I've seen the difference. Before, NHIF used to pay for a bed, what they call a rebate. It used to be an amount sometimes as low as 300 shillings, 700 shillings, depending on the level of facility you are. Then we moved to the point where NHIF now was even paying for outpatient care, which had not happened in the past. And now we're paying for specific procedures and for admissions and so on. So NHIF has had its shortcomings. Unfortunately, whenever you have any financial inflows into a sector, the corrupt people also move in, isn't it?
Yes.
Because even thieves follow the money, isn't it? So at the end of the day, there have been those challenges. The key thing is we need to learn from them. That is number one, learn from them. Part of the issue about transparency you talk about is because NHIF had got a very complicated benefit structure, all right? And part of the confusion that we had, in fact, is you've got a lot of people saying that why are some people getting this benefit and some of us are not getting it? What they didn't understand was there are some schemes that were there which were called enhanced, and there were very many of them, where you've got an employer who says, this is the basic package that you're providing, but I want my employees to get a little extra. So instead of going to a private insurance company, say, NHIF, can you do this for me? All right? So there are a lot of people, for example, the civil servants, who are getting what they call enhanced benefits. So they were able to access treatment that other people are not able to access. So that's where you find this issue of transparency. So somebody comes and says, I am also an NHIF member. I had so-and-so got this kind of treatment and I'm being denied this treatment. What has happened is, going forward, under the Social Health Authority, we're going to have a standard package. It makes things very simple, so that we know if you go for this type of surgery, this is how much we're going to compensate, whether you go to which institution, a private one, a public one, a faith-based one, that's what we're giving. If you want to be able to augment that, you can go ahead and do it. So number one, transparency is going to be in terms of the benefit package will be very clear and it will be standard across the board, whether you're the head of state or whether you're the Mamamboga.
And you can access any institution.
We will pay to the level that we're going to pay. So the institution you access is going to be your choice. Because if you go to an institution where you need to be able to pay more or top up, that is your choice, isn't it? But at the end of the day, it's going to be standard, and therefore the benefit is going to be standard. That's one to do with transparency.
Yeah.
Now, when you talk about transparency, I'm sure you're also touching on issues to do with fraud and so on. That is a system issue. The good thing is the Social Health Authority is going to be a new outfit. We're starting from scratch. All right? We are not obligated to borrow the systems and the personnel from NHIF. We are going to set up a new system. The staff from NHIF are going to get priority in terms of being able to onboard onto the Social Health Authority. But there's no guarantee. It has to be that you've met the qualifications. And so once we've set up our organizational structure, we will decide these are the kind of people we need with these qualifications, and we will competitively recruit. The issue of fraud I need to touch on again, because I know it is a sticking point. We want to ensure that the funds that go towards the Social Health Authority are used for the purpose that is intended. And therefore, in the past, there have not been such significant consequences to engaging in fraud. That has got to change. There have got to be consequences, funds have got to be recovered, people must be brought to book. And that is also enshrined, it is there in the Act, it is there in the Act, penalties are clearly stipulated, and that has got to be enforced. Yes.
And I will be back with a question on enhanced cover, because a number of government agencies were using the enhanced HIF. I remember NHIF, and I remember we used to do that here, but we have an independent cover. But you touch on that because a number of civil servants have raised that concern. But before then, Dr. Oyimba, still on fraud, we have seen also on television a number of health institutions being even investigated in regards to the claims of how they make. Of course, KU Referral is a reputable organization, but I would like you to touch on that because it's something that is also affecting a number of institutions, so that we may actualize what the head of state said, that yes, we are having affordable health care, but we want it to transit to UHC, that is universal health care.
All right, so for us to achieve universal health care, the participation and contribution to SHIF has to be mandatory. The biggest challenge that NHIF has faced has been people who are in formal employment. Say that's about 1.5 million people as contributors, and then the informal sector was largely absent. And so you find that the salaried people are contributing up to 60% of what NHIF uses to pay. And so the people from the informal sector who were joining NHIF were largely people who needed support. So myself as Onyimbo, I would contribute, and I would not use a shilling for the whole year. So that means I'm a good contributor because I am participating based on risk. So most of the salaried people were participating based on risk that one of us, out of 100 people, one person will need to use the money we have pulled together. But now there's people we are called adverse users, where today I get cancer or today I get kidney disease, and I choose that, you know what, I will use NHIF. And so eventually, from what you contribute, you're using up to 200 times of what you contributed. So that is not sustainable. But if every household in Kenya, with Kenya having about 50 million people, how many households? That's about 10 million. Yeah, a good 10 million households, isn't it?
Yes.
So if you have 10 million households contributing, and out of the 10 million, we say that probably 20% are indigent, they will not be able, or some of them are low income. Eventually, you find that we'll be able to achieve up to 70% of households in Kenya contributing. How will we succeed to have this to be mandatory? This is the biggest question we have to discuss as a community, because without resources, we will not achieve universal health care. Yet, the cost of universal health care is the 2.7% of either informal family income or my salary. If that is the cost, in my opinion, it is important. Because failure to give this 2.7, or whichever we agree, failure to that, the cost is too expensive. We have indignity, in disease, we have unnecessary death. And you know, when death visits, it's silent. It happens in Kisii, quietly, because you could not access care. So in my opinion, there's an opportunity cost. We have to choose a cost of unnecessary death and suffering and indignity, or we have to choose some shillings so that we can give universal health care. And the biggest challenge we have as a community of Kenya is to see how we will be able to get SHIF to be mandatory. I think this is a conversation.
And it's a good thing that you've mentioned the formal and the informal sector, because the government targets to net about 56 billion shillings from the informal sector from the deductions. And it's a good thing that, Doc, you've mentioned the matter of the issue being mandatory. And talking about mandatory, the question that I have posed to you first, in regards to those who are enjoying the enhanced NHIF, what happens to them?
Let me simplify this conversation. You have got an organization called NHIF, for example, and you've got an employer, and you have employees. You want employees to access an enhanced benefit. You decide to contract NHIF to provide that enhanced benefit, right? NHIF is now winding up. There's a new body coming into place. I'll say replacing it. The new body says we're not in that business anymore, all right? The discussion needs to be between the employer and the employees to say, where do we get this benefit we were getting from NHIF? Where else can we get it? And there are actually other parties who can provide that service. That would be the simple answer. So that you will get the basic insurance standard package from NHIF like everybody else.
Yes.
And if you want the enhanced benefit, you need to get into conversations with a third party, possibly a private insurer, to be able to handle it. The challenge that was there with NHIF, and I'm sure this is what advised the issue of getting rid of the enhanced schemes, is when you have got a benefit that you want to get, you're providing, let's call it a business, you're doing a business. And then you have a sibling who comes and says, you know, you wash cars, let me have my car here. You charge 500, but this is me. Do it for me for 300 or 200 because you're a sibling. I'm underpricing this. If the siblings are too many, your business goes under. And this is part of the reason that was there. When you've got government coming to NHIF, there's some relationship between government and NHIF. So you're looking at each other as siblings and underpricing these schemes. When you underprice these schemes and there are too many, it drives you under. And this is part of the reason I can tell you why NHIF was having difficulty meeting its financial obligations.
Many,
yes.
Many. And a number of health institutions have raised concerns, and actually some even stopped offering services. If at all, you don't have any other cover other than NHIF.
The stoppage was
and the turnaround
temporary
time.
At best, let me tell you. It is more talk about stoppage than actual stoppage. Let me tell you, NHIF is also, even NHIF was too crucial to the operations of most facilities that they couldn't afford to do without NHIF. Let's be honest. So at the end of the day, it is an issue of being able to agitate. And the good thing is NHIF at the end of the day gets to pay. Sometimes the delays, but they were getting to pay the bills. And I'm talking for NHIF, not that I'm at NHIF at the moment, but I'm privy to a lot of its operations and what it has done. So at the end of the day, there have been challenges. And these are the challenges that we have sought to cure with these new acts and with the Social Health Authority coming into being.
And the turnaround time, because some of the institutions have stayed for months, almost even more than 6 months, that without getting any money from NHIF, until they have to stop offering services to people who have to pay via their NHIF.
That discussion,
the turnaround time.
That discussion from the point of the Social Health Authority is premature. Premature because we've not gotten to that point. Secondly, we have said we have just launched the regulations at this point, and that is what we want, public participation. These are the kind of views we are going to be hearing. And whatever comes out in the final regulations, because they're the ones that operationalize the act, that is the time when we can be able to have that discussion. So it's going to determine, first of all, what financial projections we're expecting. Because, for example, if that number 2.75% changes, it changes our projections. It will also change the level of benefits that we can be able to offer. But also in terms of the regulations is where we operationalize and decide on those details of how, for example, providers get paid, how soon, how we contract them, and so on and so forth. So those are things that we are alive to, because, as I've said, we're going to learn from the past. We will get views from all the stakeholders. So Stakeholder engagement will occur, and this discussion will be refined as we go forward.
And maybe you can touch on that, because also KU Referral has been treating people via NHIF who have the NHIF cover, and the turnaround time in regards to from the time
payment
that you are treated to the time that the hospital is paid.
Oh, we have very good reports about our relationship with NHIF. NHIF, all our invoices are paid within 60 days. I think generally that is the credit period. And they've been meeting that, mainly because we are a major provider. I have a few things to say too, but on this topic, I would like to go back to SHIF and say the treatment for one of the biggest advantages that we saw with NHIF, and therefore we of course we're extrapolating will be with SHIF, is that they were able to cover treatment plans and packages. The following are the packages that they've covered: radiology, chemotherapy, radiotherapy. So I've said radiology and so radiology imaging, that's just imaging, radiotherapy and chemotherapy, and importantly, surgery was comprehensive for most, not all, for most surgeries. So these are packages that were being funded. However, sometimes Mwananchi would exhaust their fund. If you get, say, that you have radiotherapy 38 sessions, NHIF would pay for 20 sessions. And that would make some of our citizens drop off treatment. And that is the genius of what this chronic illness fund has come. The chronic illness fund, and the reason why I'm saying this ever so gently, is so that if you understand, Mwananchi will understand. As soon as you've exhausted your package in SHIF, then what kicks in? Chronic illness fund. And so this, to me, tells me about how thoughtful this entire ecosystem has been thought about. So that if you've exhausted your package in cancer care, you have a safety net which is tax-based. I think it is very important that Mwananchi is able to hear this, because there has been a lot of, I think generally a vacuum, nature abhors vacuums, and because there's not enough knowledge with Mwananchi, a lot of rumors are filling that vacuum, that knowledge vacuum. And the reason why we as KUTRH were happy to participate is to make sure that we are able to fill that vacuum, because we are headed in a good direction where healthcare, there's something called pillars of health. The pillars of health are about 6 as defined by WHO. And when one of these pillars is absent, you are unable to provide healthcare. One of them is healthcare financing, and this is the biggest conversation. So the others that you talked about, the digital health, about HRH, the human resource, and provision of dawa, that is medicines and technologies, and then finally governance. So if you miss, and particularly if we struggle about this topic about healthcare financing, we will not be able to give services to Mwananchi, and UHC will collapse. So this topic has to be understood and supported.
It's a good thing that somebody asked why we don't have any Ministry of Health official. Yes, we had indeed extended that invitation, but they had a crunch meeting this morning. That is why we are not having someone from the MOH. Actually, to answer a number of questions regarding the public participation, exactly, and also a myriad of questions surrounding the SHIF, because some of people are saying that we might even start deductions next week. But first things first, the public participation has to commence and be finalized, because remember, some of these recommendations do not require the approval of Parliament. Some even arguing that maybe we will have to recall Parliament, which resumes about 13th and 15th, respectively, the houses that we have in the country. But that away, Doc, we are looking at affordable healthcare, just like the head of state said, on our way to universal healthcare. How do we ensure that we do not fall into the loopholes that we had in the health sector? You had Council of Governors sometimes saying that the Ministry of Health is doing ABCD, is not doing ABCD. But at the end of the day, the train has now left the station. And the station, the final destination is UHC. What are some of these loopholes that we also have to avoid as a country?
Well, universal health coverage by definition is, first of all, access to healthcare. We want people to be able to access healthcare. In fact, it has got 3 dimensions. It's about access. What proportion of people are you covering? Then secondly, to what extent, what scope of services are you covering? And thirdly, to what extent are you paying for those services? So with this current mechanism, what we're doing is increasing the proportion of people who have got access. And that's why Dr. Ari has also emphasized here the aspect of universality. We must have everybody on board as much as possible. Secondly, in terms of the scope, I've talked about having it all the way from primary health care all the way to palliative care and referral services. So we're increasing the scope of services. And then the proportion that is covered, that is the conversation we're having, that is dependent on how much in terms of resources we can have deployed to this new venture. So there are possible loopholes, and there are loopholes, and one of the obvious ones which I see is like what Dr. Ari mentioned earlier. If we don't make this mandatory, then we've got a problem. Because the moment we don't have the numbers thrown in there, all the math goes out through the window. We cannot have certain people, like we have had in the past, where you've got erratic contributions from the majority of people. You must remember, we've got only 15% of our workforce is in the formal health sector. If we go with the NHIF model where they're the only people contributing, the numbers will not add up, right? The good thing is at the moment, the government is committed to be able to provide funding for these 2 additional funds which were not there, right? But those 2 additional funds, we cannot afford for those 2 additional funds to be used for other purposes. For example, you can't decide to draw money from these 2 pockets to try and support the SHIF because SHIF is not financially viable. All of those has to be internally viable, so the government must meet its end of the bargain in terms of providing funds for primary care and for the ECCF. And then secondly, the population, our Kenyan population must do their part and all enroll within the Social Health Insurance Fund. Then we'll be able to reach our destination. The good thing is, like he said, we also are buttressing this by making sure our health facilities are able to offer better quality services because now they have the resources at their disposal. That's why the ring fencing of the funds using the FIF bill was important. So I want people to like he said, this is work that has gone on for a long time. I don't want the perception that people say that someone woke up one day and said, dismantle NHIF and open a new one, and that it is not a decision. It is something that has been thought out for quite a number of years. So I want people to understand the challenges we've had were clearly teased out and delineated in our healthcare system. The underpinning logic for this new initiative is sound, right? Thirdly, the solutions that were crafted with ingenuity. And the implementation is going to be disciplined.
And talking of mandatory, I remember the head of state said that if you are not able to pay the 300 shillings, the government will pay for you.
Yes. And
how do we identify the legit people who cannot be able to pay the 300 shillings? Actually, we've had issues in the education sector where to identify needy but bright students has been an issue. And also we have issues, the elderly, the allowances that are given, the criteria to identify those who are genuinely needy and unable to pay the 300 shillings.
That is a scientific, there's a scientific approach to that, and there's a huge team that is working on that. It's a means testing instrument. There are many ways in which we can be able to assess. And I'll give an example. If I come dressed the way I am to this studio, and you look at the kind of phone that I have, for example, I cannot be somebody who is eligible for saying that I cannot be able to pay 300 shillings a month. So the means testing instrument looks for indirect ways of being able to gather information and estimate what your worth is. And then we peg the 2.75% of what they estimate as your income is what you're supposed to pay. Because again, it has to be clear, much as we are latching onto this 300 number, we can't have everybody paying 300 shillings. The system is not going to work.
Yes.
There are a lot of people in the informal sector who make tons more money than those people who are in formal employment. And at the moment, they're not paying their fair share. In any system, when you have social health insurance, there has to be fairness. I'll call it fairness. It's not fairness, it's not equality. So what we have proposed at 2.75 is what we call proportional contributions. Ideally, it should even be progressive, where people who earn more should even pay more than 2.75%. At the moment, what we have is retrogressive because you have got people who are earning 100,000 paying less, 1.7%, whereas other people might be paying a higher proportion, those who earn less. So what we're trying to do is make this contribution structure more equitable. And that's why I'm saying there was an issue of capping, and I know that's going to come up in public participation, whether you should cap the 2.75% at a certain amount. But that is something we're going to listen to the views of people doing public participation, and whatever comes out of it is what we're going to work with as a social health authority.
Doc, you want to add on that?
No, I support in total. I think this is the direction to go. Yeah.
And indeed, you have had issues of maybe identifying somebody who is needy. Somebody has been admitted at the hospital, he has been discharged, but he cannot raise the money. But in a way, that person can be able to raise that money. So because you are also in the industry, how do we identify legit people who need the help that the government has said that it's going to provide?
Right. On this topic, I'm very firm. We have a department called Medical Social Work, and they have a scientific tool which we can call a means testing. And so we, the board and the management has prepared facilities. We have vehicles which we send to do it's called something called a home visit. So if you have your patient and they have a bill of say 500,000 and you say no, I cannot afford, and it is my spirit, I think this person cannot afford, but I cannot for now for us to waive and take that waiver and say now we are requesting for approval for a waiver, we have to make sure that we understand who we are dealing with. We'll send a vehicle with a social worker to that person's home. If you find there's no chicken, there's no mbuzi, the house is made of grass, then automatically that's a person to waive. So you realize this is factual. But if I come and I find your place, you stay in somewhere here in Nairobi, you have a nice Subaru out there, and you're saying, no, I cannot afford, what will I say? We'll say no. The answer is no, we will not waive. And so I am very firm on this direction, because you find people who are trying to use what is called the available social safety nets, which should not be allowed. We should be very firm against such people. And the medical social work team is one of the strongest that this country has. I think this is a good feedback. But generally, to add and discuss about universal health care, and I think to be able to make this mandatory, there were some ways that had been proposed, which have now been suspended. So the ways that had been suspended was to link it to government services, that if you do not subscribe, you do not contribute monthly, you do not get you'll be denied some government services. That has been suspended by the Court of Appeal. We had some other things like trying to provide where institutions in this country, either SACCOs or banks, can provide what is called premium payment. Then we Fuliza you slowly and you pay. This can be very good, especially for the young people. We have to find ways of supporting SHA on ways to find as many people to log into this as possible. Whether we use the churches, whether we use... whichever direction, we must find more than 60% of our population onboarding to this. Otherwise, the conversation is dead before we begin.
And Doc, maybe you have information regarding what will happen to the NHIF staff that used to work at the NHIF?
I think the Act is actually explicit in terms of what happens. Like I said earlier, this is a body that is being wound up. So once it is being wound up, then the options exist. There's a new authority which has come into place. The mandate is fairly similar in certain aspects, in many aspects. So they have got the opportunity to apply for jobs within the new body. And if they are suitably qualified for the positions for which they apply, they will be given priority. So that's what happens. In the absence of that, others will have the option to, some might opt to leave, and some might opt to might get redeployed in other arms of government. Yeah.
And someone might wonder, what happens to all the pending cases in NHIF or the pending bills in NHIF? Are they absorbed under social health?
The operation of law, as when the moment the law was signed into place, all those were transferred to the Social Health Authority. So those will still be taken care of. Yes.
Doc, we are looking at more than 150 billion every year that Kenyans will contribute to the fund. So hospitals, healthcare facilities have to more or less revamp, because we're going to be having a lot of people. So a lot of people will be seeking medical help. and there's a lot of money involved. How are hospitals and institutions like KU Referral prepared for this boom?
All right. I will speak about KUTRS and generally, and also speak about this in general. So, some studies show that we spend up to 500 billion on healthcare, and out of that, out of pocket is between 100 billion to probably 200 billion. That is out of pocket. Now, if we are able to roll this out disciplined, as boss says, we will see that most of our hospitals will be sustainable. The reason is because what is being paid for by NHIF and SHIF, therefore, is market pricing. Please take note. Most of our hospitals today, if I go to KC level 5, if I go to Thika, most of the pricing today is social pricing. That to see a doctor is 20 shillings, to see a consultant is 200 shillings, to get surgery is 14,000. These are social pricing and obviously way below sustainability. Most of these hospitals, they spend a lot of Kenyan shillings to buy non-pharmaceuticals at, say, 100 million. And at the end of it, charge for none of that. And if they charge, generally whatever has been consumed and what has been given by out of pocket, you find you've spent 100 million, but what you've collected is 20 million or 100 million. It's very, the truth is that currently as hospitals are, they are unsustainable. But as soon as we start to pay for this using market pricing, you will see most of these hospitals very sustainable. And this is the genius about this entire conversation. Because today, if you get, for example, NHIF pays for, say, appendicectomy pays for about 50,000. But if you go to a level 5 hospital, appendicectomy is paid for about 8,000 shillings. So it's completely unsustainable. So my point is this: we will see sustainability. You'll find more pharmaceuticals, for more non-pharmaceuticals available. You'll start seeing a sustainable hospital. Even as you say that figure of 150 million, if we have these funds, you'll be able to start seeing what is called quality of care. The entire idea of drug stockouts, the entire idea of having challenges, we will see a better and improved outcome, in my opinion. And for us as KUTRH, we are ready to receive 1, emergency care, 2, critical care, 3, chronic disease. We are waiting for the regulations for management of chronic disease. There are some chronic diseases that have parallel funding, like HIV and tuberculosis have parallel funding from partners, but there are some which we have to take. So we will be building our clinics, like our internal medicine clinics, to be ready for things like hypertension, diabetes as chronic diseases, all of which are going to be paid for. And especially, so chronic diseases will be cared for in PHC and some in SHIF. So we will be seeing a lot of, we are preparing for that. So for the ECCF is one of our biggest conversations, and then the SHIF is another one we really have to deliver. And already as it is, we are delivering, KUTRH is delivering comprehensive care for surgery. We are also giving comprehensive care for radiology, oncology. And when I say oncology, I mean diagnosis and treatment with chemotherapy and radiotherapy. And so we are ready for that. And soon we'll be coming up with we also have it's not comprehensive though, we have a cardiac program with a cath lab, and so we are able to deal with cardiac conditions. And recently we set up a cyber knife for treatment. So it's called robotic treatment, minimally invasive. We are using radiotherapy to treat tumors in the brain, in the spine, in the lungs. And so we are trying to make sure we have as cutting edge treatment, so diagnostic and treatment modalities to benefit mwananchi. Yes.
And Bwana Chair, what Doc has said in terms of the ECCF we've talked about, Kenyans are quite reluctant, some Kenyans are quite reluctant to contribute to that amount, but looking at the benefits that are there, including mental illnesses, including psychological help, including just like Doc has talked about, some of the most sophisticated equipment that we have in the region. How do we change that mindset so that we may actualize even not only UHC, also making Kenya a medical tourist country, more or less like what we see in India?
Some of the skepticism that is there is, to some extent, might be understandable based on past experience. But I think at the end of the day, we just have to deliver on our promise. That's the best way to be able to kill this skepticism. The kind of investment that is going to increase in the health sector is going to improve the quality of service that we have here. And one day, what we are looking forward to is that we minimize this issue of cross-border contracting of health services, where you want people leaving the country and going to India. You can see the kind of investments, for example, that is there in KUTRH. These are things that a while ago you used to talk about PET CT scans. People are going to India for PET CT scans. Now we have those things here. Now you see we've got CyberKnife. We are stepping up. And let me tell you, the only way we can improve the quality and the scope of service we offer within our health sector, increasing the investment, that will also be able to mop up a lot of the health personnel who at the moment are underemployed or not employed at all. So all these things, there are benefits across the board. And eventually what should happen is now people should be coming to Kenya to be able to access care that they were going to far-flung areas for. So in terms of the aspect of medical tourism and so on. So I'd say I want people to give this thing critical thought and give it a chance, because I think, like Dr. had mentioned earlier, it's a once-in-a-lifetime opportunity for a lot of us. The last time NHIF came up, NHIF is 60 years old. And what we're talking about now is potentially something that's going to, again, take us to the next 40, 50 years. So this is a once-in-a-lifetime opportunity which we need to latch on to.
All right, all right. And of course, we're going to be talking about medical tourism when we come back, because KU Referral is already starting to do that. I remember before the former head of state left office, he introduced something that you'll tell us about. Well, you're watching KBC Channel 1 News Check. We are taking a quick break, but when we come back, we will still be delving much deeper into this issue of the social health insurance.
Siku hiyo
ulienda kwa registrar moto yako ukajua gari ni yangu.
Hiyo haikuwa kazi yangu.
No, ndio mimi nauliza wewe.
Sasa mimi hapo na hapo, kumbe nilikuwa nimegundua my eyes is not see. Why?
So inamaanisha kuwa
Why?
Inamaanisha kuwa
wewe. Sasa wewe ulikunywa gani?
Mimi nilikunywa hiyo kill me quick.
Hebu niangalie vizuri, uniambie kama unanijua.
Ni yuko wapi?
Anakuangalia na nini? Hii ni kazi ya Mungu. Kwa sababu aliambia pasta wetu ameokoka.
Niliokoka kuanzia hapo kwa
sababu ulipopotea macho.
Bali nilipotezea macho nikaokokea hapo.
Na macho yakirudi?
Macho yakirudi tutafikiria hiyo maneno mheshimiwa.
Welcome back to News Check, where we are looking at the Social Health Insurance Fund, and I have experts here to do that. We have the chairman of SHA, which is the Social Health Authority, Dr. Olweni, and thank you so much indeed for making time. And of course, we also have Dr. Oyimbo Kerema, who is the Deputy Director, Clinical Services at the KU Referral Hospital. And before we went for that break, we're talking about medical tourism, because at the end of the day, if at all we can have a number of people from other countries coming into the country, we can even have enough money or sufficient money to bring the cost of health or access to health much lower.
Yes.
And before the former President Kenyatta left office, there is a facility that he opened up at KU Referral. Maybe you can touch on that and how it can help Kenyans.
All right, I will. So, former head of state, President Uhuru Kenyatta, came to KUTRH and opened 2 centers. The first one is called the IMIC Center. So the IMIC Center is called Integrated Molecular Imaging Center. So the IMIC Center is what is usually called the PET, where we do what is called the PET CT scans. So what is a PET CT scan? So if today I have, say, cancer of the prostate, the first question is, how far gone is it? Okay, or if, say, I have a lymphoma, the first question is, how advanced is it? So what we do is we know, and this is the principle, we know cancer cells like sugar. Okay?
Yeah.
They like sugar. And so if I push sugar into your vein, the cancer cells that, the cells that will take up most of the sugar is the cancer cells, isn't it? So if I push, say, 100 mils of sugar into your body, immediately just fills up to where the cancer is. So I can actually impregnate the sugar with some color or dye and then take a picture. So that's exactly what we do. We're able first to define what stage, what level of cancer do you have. And secondly, after we have finished treatment, we do the same thing. We're able to say, now you're cancer free. And so every year we do a PET scan. Every year we do a PET scan. And so we're able to say, you're cancer free, you're cancer free. As soon as we see the slightest of areas lighting up because this sugar is running to hide there in concentrations, then we know your cancer is coming back. And we have what is called early diagnosis and early intervention. Brilliant. This is the first such facility in Africa after Egypt. And the consequence of that is we have had referrals from 26 countries as we speak. From
26 countries?
From 26 countries, from all our neighbors, from Somalia, Ethiopia, South Sudan, Tanzania, Uganda, from Burundi, Zambia, all these countries. We've had very interesting referral from India coming here, I think because our cost is effective. And NHIF pays for us, NHIF pays for us Kenyans, us contributors, NHIF pays fully. And so these are brilliant moves, and in my opinion it has revolutionized the care of cancer. Before that, by 2010, you had to go to India to get this scan done. And so, in my opinion, this is a big revolution. The second thing that head of state also came to open was something called a cardiac catheterization. So the country, public hospitals had 3. We have 4. We have MTRH, KNH, Coast PGH, and now ours. So the role we are trying to do is make sure we can provide a primary intervention PCI. It's called primary PCI. If we are able to, if you have a heart attack, if today I collapse here and I'm having a heart attack, there are few centers that their cath lab can be able to attend to my heart at a breath, that there's people on location all the time. It's very expensive to keep such highly qualified people in a place all the time. KUTRH is one of those hospitals. You can actually show up and get care. It has taken a lot of work, but we are happy to say we are trying to provide solutions in the public realm. Finally, His Excellency President William Ruto came and opened this, what we're calling the cyber knife. It's a robotic arm, very clever. Again, it is the first one in Africa after Egypt. So we are able to treat tumors which we had to either open and go deep and you know, right now we just we're using what is called it's radiation using as a radiation using that is as thin as your hair. So that makes it precision. You are just able to to radiate the disease area with minimum damage to the surrounding tissue. So those are the things that we have done that are revolutionizing. But we have also done some things that are very interesting. WHO says from diagnosis to treatment of things like breast cancer, the recommendation by WHO is 60 days. When we were young doctors, from suspicion to treatment was almost 6 months. That you have a breast lump, by the time you get a biopsy, that biopsy is confirmed that you have breast cancer. It used to take 6 months. There are many moving parts for that. But right now, the best we have done is from suspicion to treatment was 30 days.
30 days.
I'm telling you, these are things that, in my opinion, if these are our objectives to deliver as public hospitals, then we're on the right track as a country.
And it's quite commendable that already 26 nationalities have shown interest to be treated right here in the country. And because of the interest of time, Bwana Chair, I want you to speak to Kenyans in regards to Social Health Authority and what they should expect, and something that they do not know about your authority, and what to expect.
Yeah, I think just I guess in closing, it's that the Social Health Authority is, I had said earlier, is a new body. We're going to be setting it up and we're going to be rolling it out over the period of the next few months. But we are going to try and ensure that we have got seamless transition of the services, so there's no interruption of services for current NHIF members and for new members, even as we go through this transition. So the priority at the moment is going to be on delivery of service in terms of making sure there are no interruptions. I want to appeal to Kenyans to come and participate in the public participation. We're going to have stakeholder forums, we'll have public participation. We want to hear your views, we're open to those views. We want to hear what alternative solutions they have in the event that they don't necessarily agree with what we have proposed. But I think the overriding and overarching objective here is to make sure we achieve universal health coverage. We minimize the issue of out-of-pocket expenditure. We improve the quality of healthcare, because at the end of the day, health is an enabler also of economic transformation. And that's why even in the current administration, emphasis of that, health, without health as a right, it is actually very difficult to enjoy any other right in this country. And that's why it needs to be a priority. So I want Kenyans to come and participate, give us their views, and I think they'll have the goodwill from us because the intention is noble. And at the end of the day, what we're trying to do here is going to be in their best interest in the long term.
Yeah. Well said. Dr. Oyimba?
All right. So my comments are generational. We have seen efforts from those before us try to deliver universal healthcare. What we are saying, better healthcare for mwananchi. It's something that some of us have also worked on. But I can say there has never been a better opportunity to deliver universal healthcare than now, where there's political goodwill and you have people who are competent and willing to deliver. And so if there's a time that we must support, despite having some disagreements, say 20% for those who have, I think it is a time that we should deliver. And number two is really to educate mwananchi, to try and understand that we have that SHA has given birth to SHIF, PHC, and SCCF. So I think there's very many people out here who have not understood this, and people who are in policy-making positions. I think it is important that we continue having such conversations to build on the knowledge base of our citizenry. Otherwise, we'll just have a lot of gaps being filled in with rumors. I think this is very important.
Thank you, Dr. Oyimba Kerema, who is the Deputy Director of Clinical Services at the Kenyatta University Teaching, Research and Referral Hospital. And earlier on, and just next to him, we have Dr. Timothy Olweni, who is the chairperson of the Social Health Authority. You like SHA. We're putting into perspective matters social health insurance, and thank you indeed so much for joining us. And gentlemen, thank you so much for your insight and for your time as well.
Thanks for having us.
And just about the next couple of minutes, we'll be going regional, where we are looking at the South Sudanese peace accord. And remember, yesterday the head of state did mention, yes, indeed, Kenya will continue with the peace efforts that seem to have cracked, or seem to have seem to have returned to warring again in that country, the world's youngest country. Over 2.3 million South Sudanese have left their country because of the war in South Sudan. We'll be putting those and that matter into perspective when we take this short break. But before we take that break, let's first of all cross over to the Strathmore University, where the university, together in partnership with Beneath University of UK, are hosting and creating Safer Space Conference Regional Conference for Africa and the Middle East. Let's cross over for more.
But I'm also the Director, Office of Faculty Affairs in Strathmore University. Yeah, thank you very much. Yes.
Do you want to take that?
Yes. Okay. Thank you.
Yeah. So my name is Bea Bliesmann de Guevara. I'm a professor of international politics at Aberystwyth University. Oops. Shall we start again? Okay. Oh, okay. My name is Bea Bliesmann de Guevara. I'm a professor of international politics at Aberystwyth University in the UK, and I'm also the principal investigator of the Creating Safer Space Research Network. It's an international network. We were funded by the UK Research and Innovation for 4 years, and this is now one of the culminations is this conference here. We funded 26 projects in 11 countries, in low and middle income countries, from Latin America to Africa, the Middle East and Southeast Asia. And our main focus is on unarmed civilian protection and community self-protection, so really the power and the agency that civilians have in protecting themselves and protecting others in situations of violent conflict and displacement, and violences of different kind, really. So we work in very many different countries across the globe, and I think what they all have in common is that violence is not a one-off event, but it's quite, sometimes it takes decades, and people are still able to come up with ways of creating safer communities for themselves, and thereby kind of creating possibilities to actually enter into dialogue and creating safer space also for peace to happen. So I think it's really important. Peace negotiations happen at different levels and so on, but if people are not involved, then nothing can happen in terms of peace. So creating safer spaces at the bottom of that, and people are at the heart of that. Yeah.
Thank you. My name is Professor Gordon Crawford from the Centre for Peace and Security at Coventry University in the UK. And I'm part of the team of researchers that have worked on the project in Cameroon. So this is looking at unarmed civilian protection in the Anglophone conflict in Cameroon. So we're a team of UK-based and Cameroonian researchers and civil society organisations. And very much as Professor Barrett was outlining, we take a bottom-up approach to unarmed civilian protection. So we've done research with civilians from some of the most conflict-affected communities in the northwest and southwest regions of Cameroon, where the conflict is ongoing, and we've documented their diverse approaches and measures that they have taken in order to protect themselves and their families and their communities. And we've come up with a real range of different protection strategies, which really shows that local people who are affected by conflict are not just passive victims, but they are really active agents in protecting themselves and their communities.
Yeah. Thank you very much. My name is Dr. Nancy Annan, and I am also a colleague with Professor Gordon at the Center for Peace and Security at Coventry University. And this is also our partner from Cameroon, Dr. Bernard Saka, who has been with us. Just to add a little to what Gordon said, I think that one of the key things that stood out for us in our research was the agency of the local people, how they are able to protect themselves, the resilience they have in protecting themselves in the face of violence and doing so non-violently. So this tells you that you can stop conflict, you can deal with conflict issues non-violently, and that is what we are promoting in this project. How do we use non-violent means to stop violence? And also, how do we enable civilians to protect themselves in the way that the mechanisms that they use? And I think that has stood out clearly for us in our project in Cameroon. The Anglophone civilians have demonstrated resilience and the ability to protect themselves and their fellow civilians non-violently.
Most of these they are civil society organizations. How important is the government? Most of the time, the government
Exactly, and in the Cameroon case, in the Anglophone conflict case, is a very tricky and a complex one. The role of the government in this case is a bit tricky, and it's something that we are looking at. But what for us is important is the civilian and the community group, their agency in enabling a protective and a safer space for their own people. And I think that is what is being key for us. And so we are advocating for focus on the people. The heart of protection is with the people and what they are doing. And I think more attention needs to be given to that. How do we leverage those homegrown mechanisms of protection that they are using to enable a wider protection for our civilians in the Anglophone region? And I think that is what is key.
That is the Creating Safer Space Conference, Regional Conference for Africa and the Middle East, live from the Strathmore University, which is a partnership between the university and Aberystwyth University from the United Kingdom. And more, we will be getting that, which is just maybe I could touch in a second what they're doing. They're Creating Safer Space, which is a 4-year international research and impact collaboration which aims to understand and support unarmed civilian protection and self-protection amidst violent conflict. Talking about conflict, we are discussing the South Sudanese conflict, the youngest nation in the world, which the civil war has seen over 400,000 people have been killed, 2.2 million have been displaced, and another 2.3 have fled the nation to neighboring countries, including Kenya. This is according to the United Nations. The country will hold its first election in December of this year, which the elections were pushed by 2 years. 2 years. Yes, and for that and more, we are discussing that with Dak Both Riek. I'm hoping I've gotten that well. Yes, the last one has the GAC, yeah? Who is the chairman of Senior Youth of South Sudan. And better still, he's also a lawyer, so he understands the law. And being a lawyer in a country which is quite young, the youngest in the world, but still conflict. Over 400,000 people have been killed. Maybe it's to start us off. The last time we checked, there was more or less like a transitional government where the Salva Kiir, the president, had his deputy, Riek Machar. Yes. But the peace efforts kind of crumbled in 2018?
Absolutely, yes.
Tell us a history about that conflict for the benefit of our
viewers. Thank you very much, Ben Troy. First and foremost, I'd like to thank you to you and the members of the KBC for giving me this opportunity to speak with you on these important issues of peace and integration of our people that have been divided by the conflict for the last almost 50 years, because even after getting independence, there had not been a chance for people to be brought together after the crisis. So I'm really happy. As you say, my name is Dak Both Riek, and I'm really grateful to be here with you. With regards to the peace crumbling, that's true. Because remember, the peace that people were trying to implement was first signed in August 2015. It was called, Agreement on the Resolution of the Conflict in South Sudan. And then after that, it brought the two principles together in 2015 actually, and in 2016 the war broke out again in State House. That later forced Machar to run away, goes all the way to Congo, and with the efforts of many grantors, the IGAD, AU, that comes together again and signed what is called the revitalized agreement on the solution of the conflict in South Sudan, and that brought Machar back to the country. From that time to this moment, really nothing has taken place in terms of the objective of the peace agreement, reconciling the members, drafting the first constitution, and addressing the root causes of the conflict. What has really happened is that the agreement had brought Machar, to the country. But still, Machar is not moving. Since the time he stepped into the country, into Juba, he has not moved out of the capital. So it's literally in prisons, and that gives a doubt whether really there's the peace in the country. And other than that, there has been also other conflicts, communal conflict, state-sponsored conflicts that are also happening in the communities. And when that peace was also entered between Machar and Self-Care, another small party, there are also other groups known as the opposition, the non-signatory groups that are also saying, no, we don't want to be part of this peace agreement for reasons that the root causes of the conflict had not been addressed. So really, the country is partly in peace and partly not in peace.
Yeah, and the peace efforts led to a conversation in Rome where the Pope was, and I remember one of the most iconic things that the Pope did was to kiss the feet of Riek Machar and Salva Kiir.
Yes.
But unfortunately, these peace efforts seem to have collapsed in last year.
It doesn't really collapse. And before I say anything about that, I think what Pope has done was a very great demonstrations of humility. We really remember that incident, that sign of letting Kiir and Machar to humble themselves, to put the people first. But still, we do not really know, because these people are really obsessed with power. Everyone wanted to control power. They don't want to open up the society for people to, be able to express themselves, to really redirect the country. But they are still, pushing. They're still pushing. We are also there as a member of the civil society, as members of the community, to ensuring that these people must do what they must do. In ensuring that the people are brought together, the people are integrated, and the people are given what they expected of the new nation. That is to ensure that the country is made in a way that it is equitable for all. Everybody is given a space. Everybody is given that freedom to speak up of what they want for themselves. Because the independence that we achieved in 2011 was all about the people. It's all about the next generation. There was some provision that we envisioned at that time to devolve the country, to give people the power, to elect the leader they want. So from 2011 up to now, we're supposed to have our first elections in 2015. And normally when the talks of election occurs, it appears as if it triggered the violence. You remember the country has a history of violence, the history of militarized the community. Was when we were fighting for independence, we were all militarized. When you grow up as a young boy, the first thing you do is to pick up the gun to fight. So we've not really democratized. There's a lot of challenge. Whenever we talk about elections, it appears as if we are really banning the society. And a peace agreement is something that we must implement for us to be able to achieve those objectives.
And the Rome peace efforts now. The peace efforts are coming to Nairobi.
Yes.
And yesterday, I remember the head of state said that the country and himself as the head of state is more than committed to ensure that there is a lasting peace in South Sudan. I'd like you to touch on that.
Yes. It was, I think, in December when the president made a request to the President Dr. William Ruto that the peace should be brought to Nairobi, and he would be the one to mediate. The advantage of that is that President Ruto almost knows everybody. Those are his brothers, those are his colleagues. And the proximity of the country is also a factor, because President Ruto will now take it as a personal responsibility. I think we thought it's a good decision, but there are other questions that are being raised. Questions that Nairobi is not safe for some South Sudanese political dissidents, opposition, because for the last few years there has been cases of deportations of South Sudanese which end up getting killed in Juba. So, and most of the opposition leaders, which are now supposed to mediate with Kiir, are living in other parts of Africa, not in Nairobi, and some are in Europe. So they think the difficulties, and again they're also asking Kiir what transpired, because the San Egidio that is mediating the peace agreement is still ready. They have been pressurizing this group. Let's come together. Let's resolve the problem. Because remember, it was last year, early last year, when the two of them disagreed.
I think it was in March or something.
Something in March, yes. When the two parties, that's the government and the opposition, had disagreed over the agenda. The government had its own preferred agenda. It didn't want to be discussed. Others had different agendas. You understand? Now, that is the cost of the problem. If that is what prompted the president to ask Dr. Ruto, I think this is something that we'll also like to hear. Yes.
Yeah, and looking at the peace efforts, of course, my director informs you that we need to cross over to Malindi. When we come back, you should be telling us what, as senior youth of Sudan, you are doing to add to the peace efforts.
Very good.
And another thing, we have seen some of the most sophisticated weapons being used. I know we have Somali, which is a transit route for weapons, but some of these weapons, they are coming from Europe.
True.
Some are coming from Asia as well.
True.
All right. Let's first of all cross over to Malindi, where delegates are meeting at Red Cross for the recruitment drive.
Njue, we are coming to you live from Malindi constituency in Kilifi County, where opposition leader Raila Odinga is meeting ODM delegates. This is his third day of his coastal tour, and today he will be meeting delegates just to drum them up for the ODM registration drive that began on Monday in Lamu County. Yesterday they were in Tana River County, and today they continue here in Kilifi County. This is a registration drive ahead of the party polls or the grassroots elections in April. So it is paramount that the ODM delegates register themselves so that they can participate in that exercise. Now in Kilifi County there are 7 constituencies. Out of them, over 500 registered voters here are subscribed to the ODM party. Now out of those, each constituency is being given as statistics as up until now. They claim that only 65% of the registered voters, or those who have been registered by the ODM party, have yet to be registered, so they are 35%. Countrywide, it is estimated that Kilifi County is top 3 when it comes to the registration of the ODM voters ahead of the grassroots in April. Now, the several factors are coming up in these meetings here at the coast. On Monday, the absence of key top leadership of the ODM party have been criticized, including the appearance of the deputy party leader, Hassan Joho, who we are being briefed that he is away out of the country, and of course the absence of Suna East Member of Parliament, Junet Mohammed, whose absence has been very conspicuous in these meetings. There were rumors that they had been served by Shoko's letter. However, yesterday the party leader, the opposition party leader, came out right. The ODM party leader came out right and offended the space of this or the loyalty of these individuals to the party, and affirmed that the ODM party is not going anywhere. It has no problems or in-house fights, saying that the party is still strong and ready for the grassroots elections that are slated for April. So what is happening right now, behind me is a hall where the delegates are holed up. They are speaking to the Secretary General of this county, who's giving them statistics based on the constituencies, how many registered voters have been, how many ODM members have been registered per constituency out of the over 500 registered ODM members here in Kilifi County. From here, he will be heading to Marafa, that is in Magarini constituency, and he will be addressing a rally there just also to drum up some of the voters here in Kilifi County to enlist as members through the ODM party. Another important fact to note is that Kilifi County is one of the counties that voted in ODM leadership in totality during the 2022 elections. This is one of his strongholds, and we believe that him coming here to just cement and ring-fence his support base here at the course. Of course, there have been infiltration from the UDA party. Here in Kilifi County, we have seen that out of the 7 constituencies, we have Owen Baye, who is not from the ODM leadership but from the UDA party, also trying to make inroads. The Cabinet Secretary for Gender, Aisha Juma, who lost in the gubernatorial seat, has also been making some influence. So just to ring-fence that support for the ODM party, the leadership led by the party leader Raila Odinga is here. In attendance is the governor of Kilifi County, of course his host, as well as Mombasa Gideon Maitha Mungaro, as well as Mombasa Governor Abdul Swamad Sharif Nasir. Yesterday, the Mombasa governor as well as Tana River Governor Dado, they were together just to drum up support so that the voters can enlist themselves as members for the ODM party ahead of the grassroots election in April. So the Raila Odinga is yet to speak. We are still listening in to the deliberation of some of the laments, sentiments, as well as some of the issues that are cropping up amongst the members here. Once he takes center stage, of course, we'll give you those live proceedings. But as of now, we are waiting him to address, as well as the governor and as well as Mombasa Governor Abdul Swamad Sharif Nasir. However, let me hand it back to you, Njue, as we listen in, and of course at the top of the hour we'll give you more issues that continue to crop up in this delegates meeting as the ODM party leader continues with his ODM registration drive here at the Coast Region. Tomorrow he will be in Kwale County, and the next day he will be in Taita Taveta County, then wind up in Mombasa County. So we'll give you those live proceedings as soon as we have them. But for now, Njue from Kilifi County, I hand it back to you in studio.
Thank you, Njue Karisa, live from Malindi, where the ODM party party leader, beg your pardon, Raila Odinga is in the coast to drum up support for his party. Today we are having a recruitment drive between 2 and 4 p.m. at Marafa, and as you've heard, as we speak, delegates are meeting at the Red Cross in Malindi to drum up support and also try and fortify the party's strength. Remember, ODM has a strong following in the Coast Region. Njue will be back as soon as we have the leader of Azimio and ODM, Raila Odinga. But back to our conversation, we are looking at the South Sudan conflict. Yesterday, even the president did post in his Facebook account that he is more than committed to the South Sudan Peace Accord. And we have Dak Boer, who is the chairman of Senior Youth of South Sudan and also a trained lawyer. And back to the question before we crossed over to Malindi.
Yes.
I was asking about what, as Senior Youth of South Sudan, you are doing to actualize the peace. That is one. And where are these very sophisticated arms coming from?
Thank you very much for the question, Ben. The Senior Youth of South Sudan is a movement of professionals, South Sudanese young professionals, opinion leaders, whose motto is organize, not agonize. It was established in 2013 with the objective of organizing students to protest against violence and championing for good governance and against vices like corruption in the country. It's a movement of groups that have decided to step into the shoes of those who fought for independence. Because if you look at the history of people like the many leaders, in fact, those of Riek Machar, Lamakol, and even Salva Kiir himself, they joined the movement that fought for independence when they were young boys. So we're not taking over from where they left, because some of them are now even turning to become things that we do not understand. So it's a movement that is calling for good governance, is calling for democracy, is calling for revivals of our vision. That is equality, the rule of law, constitutionalism, and unity of our people. It was established in 2013, and it has, called for several good things that have been materialized in the country. We organized ourselves actually almost 1 week after the violence erupted in Juba. We called for peace, and our voice was heard. We called for several opposition leaders that have been arrested without the due process of law, and asked the entities that are mediating the agreement to ensure that these people are released and participate in this discussion. For example, when Machar was confined in South Africa, we organized many of our members, youth, that Machar should be released and be brought back to the agreement, to the peace negotiations. And with those calls, Machar was able to be released and participate in this discussion. In fact, the agreement that's being implemented is a result of our protests, result of our demands, that every member should be brought in, because the principle of negotiations were inclusivity of all members, not just politicians, but also the faith-based group, the civil society. And if you look at the agreement, I just left it somewhere, it has the signatures of several groups, though some of us are not, have not been involved in the implementation agreement, in the sense that we've not been given space, to participate in government. But we're also, playing a role outside. So that is what the Senior Youth has been doing. It's a movement that is bringing everybody together. And we are calling ourselves Senior Youth because we believe that we are a group of people that are seeking freedom for the first time. You remember, we fought for many years, and we do not subscribe to this. Our youth, the definition of youth in the Senior Youth concept is really not. It's not the way it has been defined. The definition that have been provided in some statutes, international statutes. We believe a youth is somebody who is enjoying freedom for the first time. Remember, when our country was at war, we were confined, we were not given a space. So it is now that many of us, even those who had fought for liberation, are now enjoying freedom, are now coming to school. Some of us are in primary schools, in high schools, at the age of almost starting 30 years. You find people in secondary school at the age of 40. So how do you now say these people have surpassed the age of a youth? So we are saying we do not subscribe to the definition of youth that have been provided in some statute, like the UN's conventions, the African Union conventions. So we are defining youth from our own experiences.
Okay.
Yes. So yes.
And I'm looking at South Sudan, the youngest country in the world.
Yes.
The country doesn't have a permanent constitution.
Yes.
A census has never been conducted.
Yes.
Security arrangements, something else, because actually you are having a lot of internal wrangles.
Yes.
Is this country ready for 2024 elections?
Before I come to that, I think there's something you mentioned about the weapon that are being used in the conflict. In the conflict, the UN have imposed sanctions on the government of South Sudan, and they have not been buying weapons for the last few years. But of course, there are always rogue countries in the regions and the other parts of Africa and the world. We do not subscribe to what members have agreed. So they're still sneaking in weapons, and South Sudan have been entering into agreement with certain countries, to import weapon on their behalf. So we still have a lot of weapons in South Sudan, and even before the conflict erupted, a lot of investment that were done in South Sudan were channels to the importation of weapons, because after independence, the leadership felt that they were having threats, with the Khartoum, our former country. So the target was that if Khartoum, shown its aggressive behavior, we are going to fight, which was actually done, because you remember. There was a violence that occurred, a war that occurred between South Sudan and South Sudan over the place called Heglik or Pantho. So in 2012, So what we have been doing all along was actually fighting, because the CPA, the Comprehensive Peace Agreement, had some provisions that are not being implemented. The key provision of the Comprehensive Peace Agreement were giving referendum to people of South Sudan, to the people of ABA, and conduct a public consultation for the people of Blue Nile and the Nuba Mountain. So those were not done, and from the very onset, Sudan was opposed to implement the agreement entirely. So it was implemented the agreement selectively, right? So the investment of the people of South Sudan was put in the weapon to safeguard the territorial integrity of the country, to defend the independence of the country. So guns were brought, there were a lot of guns in the country. And now when the conflict erupted in 2013, also guns were brought in. Guns were purchased. Yes, so we still have guns even after the country had experienced sanctions. Yes, and it is very worrying. It's very worrying, and that is why you find nearly almost everyone in the government had been sanctioned. People cannot travel. Either they are facing travel bans, their money freeze because of such. Guns are almost everywhere in the country. The civilians are armed, right? And that is why you find a lot of death. That's the reason why you saw those figures, in the country. Yes, but I think the sanction had helped in reducing the influx of this weapons into the country. Yes. And we are talking about 11 months, and you have been in the country. Yes. Maybe you've been in Kenya when we did our 2022 elections. Yes. And you've seen how complex our elections were. Yes. And we are developing. Yes. We are developing economy. Yes. But South Sudan is a little bit younger. Yes. We're calling it the youngest nation in the world. Yes. That's fact. We are in the middle. Yes. Of peace talks. Yes. You don't even have a constitution. Yes. A permanent one. Yes. That you've drafted yourself. Yes. And even you don't have a census, so we cannot even know exactly how the semantics are. Yes. Is that country ready for elections? The country is ready for election, whether day or night. Whether the peace talks are still ongoing? Let me bring out this thought. The country is ready for election because for many reasons. One is that the agreement had brought up a government that is so huge, with almost 700 member of parliaments, a huge government with 5 vice presidents. Very bloated. Yes, very bloated. Whatever that comes out of the national coffers goes into these people's pocket, right? So the call for election is a call for revolution, to bring in a government that will cater for their needs. I mean, a lean government or people that they elected, right? So even if there will be some irregularities, but at least the election will bring in a few people that will at least give them something, left them something for the people, for development, for infrastructure, for hospital to be conducted. That's number one. Two, the constitution that you talk about. The election itself is not an end in itself, is a mean to an end. So there are certain things, you talk about census, those were things that were supposed to be done by the forced independent government, but they have not been. Now they have been brought back. And the timeline is also very small. But look at it. We did an election in 2010, the election that, in 2010, the whole Sudan elections, before we became independent. And after that, we began preparations for 2011 referendum that give us our independence. So I think there's still time. The only problem is that we are lacking a political goodwill to be able to do these things with the speed that it requires. But I agree with you that preparing a constitution in a country that is very insecure, in a country where majority of people have left the country, it is difficult, right? And that is the challenge, because the constitution is the requirement of the agreement. The basis of election is the constitution. It says for us to go for election, we must have a constitution, you know? You get the point. And the interim constitution that we have has been made in a way that it is, behind the current constitution. They says if the constitution the transitional constitution that we have conflict with the agreement prevails. So what would the agreement is actually a constitution. So it says for us to have an election, we must first do a census for us to know the country. When we got independent in 2011, we had, according to the World Bank, 2019, they says the population is estimated to be at about 12 million. Right? And up to, at this moment, I think we need, and I believe, just like the other drafters who made the agreement, there must be a constitution. There must be a census to be conducted. But even those are there are many other, things that actually are very important. For example, the security arrangement, because the conflict has divided our country from all levels. Machar has his own army, other groups have their own army, Kir has their own army, which are predominantly, tribal. So we need, the agreement says, let us integrate, let us bring the forces together, because we can't have an agreement, Ben, when I have my own army, you have your own army, that are affiliated to you. Because the army that we have in South Sudan is, a party-dominated army, the SPLM, SPLA, right? Though it has been changed to us South Sudan, Sudan People Defense Force, but still by action and theory and policy, it's still affiliated to one party. You get that? So you can imagine from here, from where you sit, a country that will go for election without those things, without security, arrangement being completed, without a census, without a constitution. But there are certain things we can do. Yeah, right? For example, if we open up the society where I am able to express myself, because this conflict is characterized by extreme abuse of human rights. People cannot be able to really speak up, right? The president in 2016 established a national dialogue, committee that went around and asked people. And the recommendation of those people, of the people of South Sudan, was that President Salva Kiir should step aside for us to have a smooth transition.
It makes sense, because the two gentlemen have been in power since Sudan became a republic.
Yes.
And unfortunately, they have never had an opportunity to agree and form a government. But now we have a chance, because we have elections. But most likely, unfortunately, we have one of those two leaders as a head of state. Do you believe that we'll have a change, or as a country you believe maybe we need fresh blood?
If people do not manage this election, there will be a genocide, I'm afraid. And it's good we are saying this early. This may be very strange words, but the facts on the ground lead to this direction. Because if the 2015 elections, when we had not died a lot in that number, causes this conflict, now we are going to, the elections period have arrived when we have not even really shake hands. Machar himself cannot move out of Juba, cannot even attend church service since 2018 when he went to Juba. He's just been confined in Nairobi. The other opposition parties, the chief of staff, several army officials are outside. This group now that I want to meet with the president.
And I'm hoping, that there will be lasting peace, because the head of state our head of state has expressed personally that he reached out and hold out opposition party and expressed his desire to ensure that an inclusive and equitable mediation. Away from that, you've mentioned something that the UN has also mentioned in terms of human rights perspective. We continue to document serious cases of human rights violation. And here at KBC we have a program called Military Tales. I've interviewed military veterans who have been in numerous United Nations peacekeeping missions in South Sudan. But unfortunately, we're talking about 400,000 people murdered within a space of less than 10 years. Do you believe that South Sudan maybe needs more peacekeeping forces, and especially in the light of the elections that you're going to hold?
If you look at the number of the peacekeeping forces that are in South Sudan, they're sufficient. But at some point we think they are not doing enough. And that is also not good, because we cannot keep complaining, because the problem emanated from the bad leadership that we have in the country. I think they have done quite well. I think at the moment, I can say it's one of the countries that hosts a number of, foreign groups, either NGOs, because, and UNIMIS, the United Nations mission in South Sudan has been doing a lot. Almost literally every state has got an IDP camp. They are the one, protecting those people. I think I would not suggest that we need more peacekeeping missions. The one that we have in the countries are enough, and they're doing a good work. The only problem is that they are dealing with militants, rock leaders who do not adhere to what they had agreed on. Because sometimes you'll find whenever the conflict erupts, people will storm UN camp, want to kill vulnerable people. Yeah. Against the military rule, right? Killing non-combatants is something that violates the military, principles. You don't do that, and themselves they know, because they have been, they're well trained even before, during the Sudan's day. I would be shy to say we need more. My only suggestion would be that they speak up very well. They speak up boldly against anybody among these principles who do not adhere to these rules. My state, where I come from, is literally a state governed by the UNIMIS, because almost everybody is in IDP camp, and they are the one protecting the civilians, right? And I believe they are doing a wonderful job. They're doing a wonderful job, and they still need to be there. We had protested. There was a time when they said they wanted to move out, and we protested, say no, you have a duty, and through our calls, the mandate has been extended by the United Nations, and because of several vices that are happening, the abuse of women, the children, also being illegally recruited to the army. So when they leave, they will now give room, for these combatants to actually recruit children into their camps, into the military camps. So I think they are doing a wonderful job, and the only thing we can do is to call on them to do more. Because if you remember, there was a time, especially when the crisis occurred in 2016, several groups actually attributed blames on some of them for being reluctant. And then another call is also on institutions that have been established by the agreements, institutions that are charged with the responsibility to implement, to oversee the transition. They're also not speaking up. I think they need also to do more. To press on the people. Actually, because that will lead to people having confidence. Confidence in these processes. Confidence in believing that the election will be done in a manner that will be transparent. So human rights is really an issue. If you look at the recent report by the Commission of Human Rights in South Sudan, titles Entrenched Oppression, you will find, the civil space as shrunken. It's completely almost not there. And that is the recipe for disaster. When you have, because some of our justice, some of the justice that we want, Ben, is also we need to speak up of what we want to see in our country. All right. We're not really saying give me this. No, we're not saying leave me free to speak of what I want. Yeah. We're not saying no. Some of the things, because there are several types of justice, restorative justice. A lot of things that happen. You cannot really bring me back. If I've lost my house, if my home had destroyed, you can't take me back. It is difficult. But let us restrain ourselves. Leave me to grow. Leave me to think. Because the Constitution emanated from the views of the society, our cultures. We had a constitution, the Constitution of Sudan, that wanted to Islamize everyone, wanted to Arabize everyone. We are saying, no, we are African. We want to do our things our way.
All right.
Yes.
All right. And because of the interest of time, I'm looking at the conflict in the region. Yes. Your big brother, Sudan,
yes,
is in a civil war.
Yes.
Looking at Ethiopia has had its share of conflict in the Tigray region.
Yes.
Somalia is another story altogether.
Yes.
do you believe these are some of the things that are fueling the conflict in South Sudan?
We think. So
the conflict in the region.
Yes.
Because mostly you find that when a country is having some turmoil or civil war, another one, you are surrounded. Actually, Kenya, we are surrounded by countries. A good example is Kenya. We are dealing with Al-Shabaab from another country who are fueling the insecurity in some parts of the country in the north. Do you believe that some of the conflict in the region are fueling the fire in South Sudan?
Absolutely. Because when you remember earlier, you talked of proliferation of weapons. Sudan covers big parts of it's actually a big neighbor, because if you look at the northern part, Sudan borders almost 4 states, starting from Malakal, Unity States, Jonglei States, all the way to northern Bahr el Ghazal. So with the crisis in Sudan, a lot of weapons have come in, and what you say is true, because conflicts has been part and parcel of the Sudanese history. There is no time, and that's why you find President Museveni the other day was saying, we cannot always solve problem through violence. You term them unprincipled wars. Because there are certain conflicts, certain disputes that can be solved by negotiation and people coming together. So this behavior of people fighting has also been something that people are learning from. Because why would Sudan be descent into the crisis? That violence that's happening in Sudan is uncalled for. Because they have just removed President Bashir through the People's Revolution, and the agreement was that, which was actually brokered by IGAD, was that the military was to be part and parcel of the transition.
All right.
In about 8 months, and they are now going now to proceed the elections.
Okay.
Now this conflict erupted between the two generals who are actually buddy. But so this war is really uncalled for, and we need serious actions. The mediators should see into it that this behavior among the Sudanese people should be brought to an end.
In 1 minute, in 1 minute,
Yes.
Your final sentiments, and more specifically, you can touch on the role of the youth in supporting the country in peace efforts and in the upcoming elections.
Thank you so much. The youth are an integral part of our society, and they have a huge role to play, and they have been doing that for over the years. I wanted to remind them of the statement that was once made by John Kennedy, who said that ask what you can do for your country, not what a country can do for you. So we have a duty to play. We do not need to be complacent. Nobody is going to do this for us. The future is ours. So we have a duty to speak up. To speak up, to pick what you think is possible in ensuring that peace is implemented, because we are literally the one that are in the field. The elders do not fight. South Africa do not fight. One example was when the conflict occurred in 2016. They were in one room and they didn't fight. So we cannot continue to be used as a powder of war. The only power we have is to speak up and to avoid, non-violent. We are the glue that can bring the country together.
Thank you so much, Dak Boath, who is the Chairman Senior Youth of Sudan and also a trained lawyer, putting things into perspectives in regards to the peace efforts in South Sudan. Remember, now the talks are here in the country. President William Ruto yesterday affirming his commitment and the country's commitment to ensure that our neighbors and our brothers, South Sudan, have lasting peace and in the wake of elections this year. Of course, we will be keeping tabs to know exactly how the peace efforts are going on from Rome now to Nairobi. And thank you indeed so much for joining us. My name is Njue. It's always a pleasure. Let's continue the conversation on social media. Lensa Odingo was our sign language interpreter when we began, but now Anwangeshi is our sign language interpreter. Khalid Abdullahi is coming up next with Tamrin and Kurunzi Mashinani.